Καλησπέρα σας κυρίες και κύριοι, καλώς ήρθατε για άλλη μια Κυριακή στην εκπομπή μας Θέματα Υγείας. Κάθε Κυριακή την ίδια ώρα στις 7.30 το βράδυ. Απόψε έχουμε έναν πολύ ενδιαφέροντα προσκεκλημένο και χαίρομαι πάρα πολύ που είναι εδώ μαζί μας, τον Dr Giorgio Lambru. Είναι Έλληνο-Ιταλός, μιλάει ελληνικά, μιλάει και αγγλικά και αποφασίσαμε, επειδή του είναι λίγο πιο εύκολο, να κάνουμε την εκπομπή μας σήμερα στην αγγλική. Και αυτό προς ευχαρίστηση κάποιων τηλεθεατών που όλο παραπονιούνται ότι τα λέμε όλα στα ελληνικά και δεν καταλαβαίνουν. Οπότε ας κάνουμε έτσι και μια διαφορετική εκπομπή στα αγγλικά. Καλώς ήρθες.
Ευχαριστώ.
Και ευχαριστώ πάρα πολύ που ήρθες. Θα πω δύο λόγια για τον Dr. Lambru και μετά θα ξεκινήσουμε τη συζήτησή μας. Είναι νευρολόγος, είναι consultant neurologist, είναι στο τμήμα διαχείρισης πόνου στο Pain Management και Neuromodulation Center στο Guy's and St. Thomas. Neuromodulation είχα μιλήσει στο παρελθόν πριν κάποιες εκπομπές, είναι η νευροτροποποίηση. He leads the academic multidisciplinary headache and facial pain center. Ο Dr. Lambru σπούδασε στην Ιταλία, στο Πανεπιστήμιο του Μιλάνου, αποφοίτησε το 2004, μετά εκπαιδεύτηκε στην νευρολογία στο Πανεπιστήμιο της Πάρμα. Συνεργάστηκε κλινικά και ακαδημαϊκά με το Headache Center of the University of Parma από το 2005 έως το 2009. Έκανε κλινική επιδημιολογία έρευνα στις ημικρανίες, πονοκέφαλο ημικρανίες. Επίσης δούλεψε αυτό μου έκανε μεγάλη εντύπωση, στο Department of Neurology, Neurocritical Care Unit at the Jackson Memorial Hospital στο Miami.
That was an experience, yeah.
It must have been. It must have been. Across the Atlantic, everything is exciting. 1-year clinical fellowship within the headache group at the National Hospital of Neurology and Neurosurgery. And you developed an interest in cranial neuralgiform disorders. That's very interesting. And has led him to undertake PhD in 2011 at the Institute of Neurology in UCL, Londino. Actively involved in clinical research in headache medicine, has authored a number of scientific publications, presented at national and international headache conferences. Welcome, very exciting Dr. Lambru.
Thank you very much for inviting me.
My pleasure.
I'm very pleased to be here. So we embarked in this experience at Guy's St. Thomas's, which involves the diagnosis, the understanding and the management of complex headache and facial pain disorders. And it's, these type of headaches are quite multifaceted conditions, and they require a multidisciplinary setting. So normally I see patients with headaches all the time, every day, difficult types of facial pains, and normally the patient that I see have been already seen in primary care by other neurologists, by pain consultants, and when they sort of don't know what else to do, they refer them to me. And at Guy's St. Thomas's we have the opportunity to treat them with a broad variety of therapies, from tablets to neurostimulation, injection therapies, and also psychological treatments like cognitive behavior therapies and other treatments. And also we're quite a lot involved in research in headache, clinical research mainly, trying to discover new therapies for these highly disabling conditions, but also preclinical research in animal models to try and understand what causes the headache and what do the treatments cause in the brain when it comes to therapies for the management of headaches.
We had our common friend a few weeks ago, a couple of months ago actually, Dr. Cantuli, Zinais, who's a very good friend of both of us. And she told us a lot about the things you do here. You're a wonderful hospital, and obviously you have the opportunity to do a lot of research. How many cases of headaches do you have? Because I think it's a very common symptom. Myself as GP, I see a load,
Yeah.
And I suffer from migraines myself, and I think loads of women suffer as well. How do you have a few thousands, a few hundreds?
Yeah.
And do you see from wide areas of London, outside London, or is it specific areas you see?
So we have our catchment area in south of London, so Lambeth. Mainly, but of course, being a tertiary referral centre, we see patients from the whole town, so London and across the country. So
nice.
I see patients from Yorkshire, down south, and also some patients from Scotland, but the NHS system is quite different there. So we have quite a big cohort of patients, and as you said rightly, headache is probably one of the most frequent symptoms. It seems that almost 96% of people will have a headache at some point in their life. Migraine is the most common disabling condition. So we're talking about 11% of the general population. The ratio between female and male is 3 to 1, so it's more frequent in females.
Correct.
There is another form of headache, which is tension type headache, which is much more frequent than migraine. We're talking about almost 50% of the general population will have some tension type headache, but it is not that disabling. So I don't see those type of people in my clinic, because they normally don't require a lot of treatments.
Do you see specifically migraines?
So we see all the most disabling headache condition, and as you probably know, if you look at the classification of headaches, there are over 200 different types of headaches. So the vast majority of them are primary. So the headaches is the symptom and the cause. So if you do MRI scans, CT scans, you don't find any underlying pathology of the brain or of the craniofacial structures. But then there is a small proportion of them which are called secondary headaches, where the headache is a symptom of an underlying condition, which can be a brain tumor, a bleeding, a hemorrhage. Can be there are headaches called post-traumatic headache, where a whiplash injury or a head trauma can exacerbate a continuous headache. There are other metabolic disorders and disorders of the craniofacial structures, like the teeth, nose, sinus, ear, and they can all cause headache or facial pain.
Any space-occupying lesion, actually.
Yeah, exactly. So, but this, when it comes to secondary headaches, normally there are red flags. Apart from the headache, there are other atypical symptoms. And when you examine the patient, when you take the history, you normally find these red flags and you send them for investigation. You can exclude those group of patients. So the most important part of our assessment when it comes to headache patient is taking the history. Correct. So taking a correct headache history is the most important part of our consultation. We don't have biomarkers for migraine, so we can't do a blood test like diabetes or thyroid problem and figure out that you have migraine or not. It's all about taking the history and a good neurological examination. So once the secondary headaches have ruled out, then we have to deal with the primary headaches, which are the vast majority of the headaches, and some of them are highly disabling, and that's of course include migraine, but there are other rarer form of headaches that we can talk about even later, such as cluster headaches, some types of facial pain, such as trigeminal neuralgia, and the variant of trigeminal neuralgia that normally lots of primary care physician encounter in their practice, and sometimes they can quite difficult to be treated. So in the main, we see people with chronic migraine, but because there are different variants of chronic migraine. There are migraine without aura, where the pain is the predominant feature. There are people with migraine with aura, where they get these transient neurological disturbances like visual problems or sensory disturbances, or motor problem like weakness in one part of the body, followed by the headache.
Which is a big confusion to us, because sometimes you think it's a stroke and they're really concerned themselves. They think they have stroke-related symptoms, which is not, or TIAs even.
Absolutely. There are some features that can discriminate between a TIA or a minor stroke and an episode of what we call hemiplegic migraine. But you're right. So these people normally have 4, 5, 6 MRI scans. They all turn out to be normal, and then they need to see a specialist to sort of get through the treatment pathway. But then there is the most disabling probably variant of migraine, which is chronic migraine. So in headache medicine, and especially migraine, we discriminate between episodic migraine and chronic migraine. So episodic migraine means that people have less than 15 migraines a month for more than 3 months, whereas chronic migraine is when people have more than 15 headache days or migraine days per month for more than 3 months. And chronic migraine is certainly one of the most one of the worst burden for patient, for primary and secondary care, and for the society in terms of obviously an economical burden, because these people
cannot work.
Yeah, if they either don't work, so the unemployment ratio is relatively high in people with chronic migraine, or if they go to work, they don't perform as they should. They can't stay in front of the computer, they can't sit down. If they get a migraine, they have to go away.
Photophobia.
Exactly. So all the environment, the environmental factor can actually worsen the headache. And the other, so certainly chronic migraine is the group of patients that need a referral most of the time to a neurologist or a headache clinic for their management.
Shall we refer?
It depends on how comfortable the primary care physician is. So if they have an interest in headache and they can manage chronic migraine, they are comfortable with the diagnosis, then we probably, get referrals after the patient failed to respond or tolerate 3 or 4 preventive treatments. Because the key aspect of the management of chronic migraine is certainly not to get into the excessive intake of painkillers, which is the main problem we have in clinic, which is called medication overuse headache. So if you have more than 15 headache days a month, what patients tend to do is to keep taking painkillers in the hope that the headache will subside. But normally what happens is the other way around. So taking excessive amount of painkiller can actually worsen the headache and make it chronic and daily and continuous all the time. And also, if some research show that the more painkiller you take, the less the preventive treatment tend to work. So even if you try medication like amitriptyline or propranolol, that tend not to work as well as it should if the patient are taking. They've got lots of side effects.
Definitely, yes. What about sumatriptans? Or you will tell me when we get to the treatment?
Well, so the main treatment of migraine is divides in acute treatment and preventive treatment.
Okay.
So normally, if you follow the guidelines, to abort a migraine, we tend to use acute treatment. But then we have to make sure that people don't have too many migraines and then they don't exceed in taking this medication. So if you look at the acute treatment, there are 2 big families. The aspecific painkillers, paracetamol, ibuprofen, diclofenac, naproxen.
Codeine very often.
Well, we'll talk about that in a second. That's a very, very important topic.
I want to ask you.
And then there are specific treatment, the triptans. So the triptans have certainly revolutionized the management of migraine since the early 90s. There are different types of triptans. Sumatriptan, as you said, is the most frequently and widely used. And it comes in tablet, nasal spray, injection. So sumatriptan, they are agonists of the serotonin receptors, and they act in the trigeminal pathway and also in the brain, in the thalamus, in the brainstem. So what they do, they stop the in most of the migraine sufferers the trigeminal activation, which is the arm, the efferent arm by which migraine presents. And so when you have a migraine, there is a peripheral sensitization, so there is a sensitization of the trigeminal neurons that then goes retrogradely to the brain and causes central sensitization, which is normally manifesting with sensitivity to touch. So people with migraine will tell you that in the painful area, they can't really touch it because it's very sensitive. That's central sensitization. And triptans tend to work very well if they're taken at the very beginning of an attack, because they stop the peripheral sensitization and in turn the central sensitization. The problem with triptans is that they can cause side effects. They're contraindicated if people have cardiovascular problem, uncontrolled high blood pressure, history of stroke or heart attack. But in the main, in the young migraine population, they're relatively safe and effective.
Usually they ask for it. And by the way, may I ask you, what do you think about pizotifen? Because it was something that was given even before the triptans, I think. And it's still very popular in primary care.
It is very popular. The evidence are quite mixed. There are very old-fashioned studies that have shown some efficacy in migraine. The problem with pizotifan is that there are two main problems, and certainly the tolerability profile is an issue. It makes people put a lot of weight.
Oh, really? I didn't know that.
So
not to prescribe again.
So it increases the appetite and it makes people relatively drowsy. So normally the people with migraine are young people and people that want to perform, they want to go back to work. They're normally very active. So giving a medication that can cause drowsiness and weight gain is sometimes something that people don't really want.
Correct.
So in secondary care or in headache centers, we normally don't use it very often.
That's a very nice thing to say and to know for a primary care physician, because you know many treatments are cost effective, and some people decide according to the cost rather than the side effects. Absolutely. Or what would be beneficial for the patient. Very nice, very interesting. So yes, please continue. I don't want to interrupt your
I think
flow.
Well, if we slightly go back to the management, so we mentioned, because you mentioned codeine before, yes, and I think it's very important. So if you look at the NICE guidelines in the UK, but this is something that I used to do even when I was working in Europe, we don't prescribe opioids in migraine. So opioids are highly contraindicated in migraine management. If you look at the NICE guidelines, they say don't use opioids, and with opioids I mean from codeine all the way to tramadol and morphine. Patches, buprenorphine is something that we don't use, and the reason is they tend not to work in migraine. So when people with migraine tell you that they're benefiting from opioids, is because they make people feel sleepy, they go to bed, then they wake up and they feel better.
They're not functional.
They're not, yes, but it's not because of the analgesic property of the medication. So, and the other caveat with codeine is that it can cause addiction. People tend to use them quite often, and they can actually go into the medication overuse issue. And when they overuse codeine, then withdrawing the codeine becomes really difficult, and people get into withdrawal symptoms, and they tend not to stop it, and also the preventive treatment tend not to work. So when it comes to the management of migraine, normally we advise either a strong anti-inflammatory with possible a prokinetic, so an antiemetic medication, or a triptan that can also be combined with an anti-inflammatory if needed. But then the sort of center of the treatment in chronic migraine is prevention. So, and by prevention I mean, of course, lifestyle modification. So, people with chronic migraine sometimes are not active. Their sleep pattern is not regular.
Correct.
They normally take too much caffeine, which can be a chronification factor. Their mood is not stable. They've got lots and lots of comorbidities. So the aim of the preventive treatment is to identify those comorbidities and tailor the treatment around the patient. Nice. Talking about medication, which is one of the most one of the best treatment we've got. Certainly, topiramate is the anti-epileptic medication and the migraine preventive treatment that has the best evidence.
Topiramate.
So topiramate is, if you look at the NICE guidelines, they've just been reviewed, topiramate is at the top of the list. So if you have someone with frequent migraines or chronic migraines and there are no contraindications such as kidney stones or glaucoma, topiramate is the drug of choice because it's highly effective, and that has been shown in 2 randomized controlled trials. So normally in secondary care we tend to use that quite often because some of the primary care physicians are not very comfortable with antiepileptics. So they prefer the neurologist to start the treatment and then they continue it.
May I ask you, have you used Keppra, levetiracetam, before topiramate? So
levetiracetam, it works in a different brain pathway, so more in the glutamatergic neurons. So if there has been some studies showing some promising effect in migraine, but then others didn't confirm the results. So we normally don't use it in migraine or cluster headache therapy. Whereas topiramate works in the glutamate pathway, but also as a sodium channel blocker. And we know that sodium channels can be altered in migraine.
Do you have the right as GPs to prescribe that, or is it better to refer to a specialist?
So if they are happy with the titration, with the tolerability profile, they should prescribe it.
Are there any bloods or any investigations we need for monitoring?
No, the main aspect to be careful about is make sure the patient has got no major contraindications, and obviously we need to inform the patient about the potential side effects. People can have tingling in their fingertips, their mood can swing a little bit, they lose weight, so that's the only medication that causes that. So in some people where obesity is a comorbidity, that can be very, very handy.
Women will be happy to tell them that apart from treating your migraine, we will help you lose weight, so they will be excited.
Well, and also because, absolutely, because most of the other treatments actually have got the opposite effect. And this is the main problem we have with migraine, that we have to borrow treatments from different specialties. So we use beta blockers from blood pressure, so cardiology, we use the antiepileptic for epilepsy, we use the antidepressant, but we don't have even though there are some research coming up, we don't have a specific migraine treatment apart from triptans.
Correct. Okay. And what other therapeutic interventions do you have?
So I think the other treatment that probably has made a huge impact in migraine management, especially chronic migraine management, has been botulinum toxin type A. And so the Botox that is used for cosmetic reasons, and actually the reason why that has been discovered is because women were having it for the wrinkles, and then they found out that their headaches were getting better. So that sort of led to a massive research in migraine prevention, and there has been several phase 2 and phase 3 trials. And recently, in 2010, there has been a very big trial, the largest migraine trial that has ever been published, testing Botox in prevention of chronic migraine. And that study was highly positive. So it showed that about 50% of patients with chronic migraine will have a 50% reduction in their migraine days after 2 cycles of Botox. And 25%, there is a small proportion of this patient that actually get over 70% improvement, which is, for a condition that is a burden, people don't function properly, is a huge step forward. And I've got quite a lot of patients actually managed to go back to work, so which for the society and in terms of cost effectiveness is a huge improvement.
May I ask you regarding Botox? Have you finished? Sorry.
No.
Because I have a question, might sound naive. I mean, Botox, women having corrugators and proceros in the front, but the migraine type of treatment, it's in the scalp.
Yeah.
Isn't it?
Yeah.
So it's just different sides. And how doing facial treatments that influenced the improvement of the migraines? That's one question. The other question is, how often do you have to do Botox to get migraine symptoms relieved or subsided? So
in migraine prevention, Botox has been tried intramuscularly, so within the muscle. But the actual mechanism of action is not muscle relaxation, but is targeting the sensory nerves within the muscles. Right. So there has been some preclinical studies that show that what Botox does in the peripheral, like trigeminal and occipital nerves, is modifying the release of certain migraine peptides. Okay, so vasodilators like CGRP, substance P, all these chemicals, all these peptides that cause peripheral sensitization, so that cause the sensitization of the neurons. Botox stops that release or reduces it, and if you don't have a peripheral sensitization, so if the nerves around the head are not sensitized, the brain becomes less sensitized and the migraine decreases. Very interesting. So the protocol that we use is quite strict, so we can't just inject randomly. We have a strict protocol which entails 31 injections all around the head. So we do...
In one session?
Yes. So we do 7 in the forehead, 4 each side of the temporalis, 3 at the back in the occipitalis muscle, 2 in the paraspinal, so side of the neck, and 3 in the trapezius, the shoulder. Because in migraine, quite often the neck is involved, it's painful, it's stiff, and also the shoulder, so the pain can radiate to the shoulder. So no matter where the migraine is, every patient that comes for a Botox therapy gets the 31 injections.
Very interesting.
And going back to your second question, how often? So the trial shows that you have to have 2 sets of injections, so 31 and then 31, 3 months apart. And after 2 treatments, then you can assess the efficacy of the treatment. Now, if it's very effective, then most of the patient keep having the Botox every 3 months.
How many sessions can you do in total? 5, 6?
You can do as many as you want.
There is no limit.
No. So there has been a few safety studies that show that you can even do it for 5 to 6 years, every 3 months, and it doesn't cause any side effects. We have patients that have been having Botox for 7 years, and their migraine is almost suppressed. But if you don't do the treatment, it creeps back up. So they have to have the treatment every 3 months.
Very interesting. Very nice knowledge, which is very much above range, above average, actually.
Unfortunately, the treatment. So I think with topiramate, Botox is probably one of the best treatment we've got for chronic migraine, but not many people can actually get that. Even though on the UK NHS system is free. It's free if you have certain. So if you have a certain type of migraine, so a migraine that hasn't responded to at least 3 treatments. So for example, we go back to the pizotifen, amitriptyline, topiramate, or propranolol. If the migraine hasn't been responding to those treatments, then people are suitable for Botox, and they're referred to the Botox clinics. So we for example have 3 Botox clinics a week, and we inject quite a lot of patients every week because we have quite good outcomes. I
can believe so. And I believe there are not many people trained in Botox regarding migraines. It's a special training. Very nice. It's good to know, actually, that we have a therapeutic option as well. What else do you want to tell us about migraine? Anything you consider it's helpful to our viewers?
Well, I think there are many aspects of migraine, and I think one is understanding. So the first point that I always ask in clinic is, oh, I don't think I have migraine because I don't have the visual symptoms, the flickering lights. So we know that in migraine, just a proportion, about 30% of patients will have the so-called aura, the visual symptom, the zigzag lights, the bright spots. But the vast majority of people with migraine will have the pain with nausea, vomiting, and sensitivity to the lights, noises, and motion sensitivity. So that's the first thing. You can have migraine without having the aura, and it's exactly the same thing. So it's still migraine. The other very interesting, I think, topic that is not known to many people is the triggers. So what does bring on a migraine?
Correct.
Because many people think that, well, when they come to me, they're like, doctor, I've cut everything, I've changed completely my lifestyle, I'm not eating anything, I'm not eating cheese, chocolate, and carbs or anything like that, because I've read that those can be triggers. But this is not true.
No?
If you look at the data, this is not the case. So we don't really recommend people to avoid things, because then you end up having this avoidance behavior where I don't take this, I don't eat that, I can't go. So exactly, and that can actually worsen the migraine because you become more withdrawn and stressed about things. Whereas there are no evidence that show that these elements and this food can actually cause and trigger the migraine. So unless people have a specific food or a specific trigger, we don't recommend any change in lifestyle. What matters in migraine is keeping a very balanced and steady lifestyle in terms of sleeping hours, in terms of the time when they eat, in terms of water intake, coffee intake, because what happened in the migraine brain is that it seems that, of course, migraine is a multifactorial condition. So you have a genetic predisposition and you have the environment that plays a major role. So what happens in the migraine brain is an energetic issue. So in certain situations, the people with migraine, the migraine brain itself feels under threatened from environmental factors. So lack of sleep, stress, tiredness, changing weather, they can all be perceived by the migraine brain, or hormonal fluctuation. Think about menstrual migraine. They are all felt as impairment in the energetic balance of the migraine brain. And the only way that the migraine brain can survive to these threatening environmental factors is by giving a migraine. So when a migraine occurs, then the energetic levels are rebalanced, and then people can carry out their normal life. So this is something very important when it comes to migraine. Don't avoid, but try to keep a steady lifestyle as much as possible.
Right. And from what I know, you have really exciting, interesting, unique ways of treating, many options, many alternatives in treating migraines, and you use some methods which are not commonly known or used in other places. Would you like to tell us about those? Because I'm looking forward to hear all about it.
Yeah, so there are the problem, as you mentioned rightly before, is that we have limited pharmacological treatment for migraine. We have limited evidence for tablets, and tablets can cause lots of side effects. So our people that are young, they want to perform, they want to go back to work, they don't really want to stay on tablets that can cause cognitive side effects, can cause low blood pressure, they can cause overweight. They want to, you know, we would like to try and find some treatments that don't cause lots of side effects and that can be well tolerated by our patients. So because of that, because of the fact that many patients don't tolerate our treatment, there is a group of patients that they don't respond to anything. Okay, so we try many drugs, we try some of the injections, and they just don't get better. And this group is quite a difficult group to treat. And for that reason, there has been, over time, quite a lot of effort in terms of researching new technologies, new treatment, new ways of managing this complex condition. And one of them is neurostimulation. So neurostimulation has been in the new frontier for migraine and primary headache management now, I would say, for 15 years. So the main treatment that we have been using is occipital nerve stimulation, which is a treatment that we tend to limit for those with chronic headaches, especially chronic migraine, who are refractory to medical treatments. And because at the end of the day, it's a surgical procedure. So what happens is we put 2 electrodes underneath the skin over the occipital nerves, so it's across the back of the head on both sides, because migraine can be on one side, can be on both sides. And the electrodes are connected to a battery, like a TENS machine or like a pacemaker of the head, really. And the battery is placed in the abdomen or the upper buttock, and it delivers continuous electricity. So the electrical pulses to the nerves tend to modulate the brain pain pathway and cause pain relief.
How long does it have to stay there?
Well, normally is a long-term treatment. So people
they go home with that?
Yes, there is an implant, so it stays in the body. Okay, so they charge it every 2 or 3 days. They feel the stimulation in the back of the head, and basically they keep the stimulation 24/7, so all the time.
Is it practical to have 2 electrodes on the occipital area of your brain and of your scalp actually, and work? And it's something visible, isn't it?
No, well, it's not. It's not, because you see just a small scar at the back, but normally it's covered by the hair, so you virtually don't see anything. And people prefer the pleasant buzzing, or how we call paresthesia, at the back of the head, rather than having awful migraines. And you know, if you can go back to work, engage in your social activities and family activities, that's a small price to pay, I think.
How long does the implant stay there? So months, a year?
No, the implant. So the implant is a permanent implant.
Permanent.
And then it can be revisited over time. So people come to our clinic. We check the system. We check the stimulation parameter. But it's a treatment that can be kept for 10, 15 years if it works.
Amazing.
Of course, if it doesn't work, it's a reversible treatment, so it can be taken out. So in migraine, there has been a lot of research. And it seems that there are some people that benefit quite a lot from this treatment, but we have to make sure that this treatment is delivered in tertiary referral headache center, because obviously you need a multidisciplinary team to look after the patient. You need a pain psychologist, a physiotherapist, an expert in neuromodulation. You need nurses with a special interest in headache that can follow up the patient, see if there is any side effects, and then of course they need to be seen by us to see how they are doing. And after occipital nerve stimulation, of course, there has been a lot of other research trying to find even better treatment for our patient. So recently there has been a lot of interest in non-invasive devices, so devices that are not implanted.
I have seen a couple, and I'm looking forward to hear of those as well.
So, because of course having surgery so these occipital nerve stimulation devices are very expensive. So we're talking about over 20,000 euros. Yes, each implant.
Are they provided through NHS?
In specific cases, NHS England can provide it if patients are assessed by a specialist team and if they are refractory to other therapies. But exactly, because of the price, we have to have specific selection criteria for our patients.
So very strict, I can imagine.
Absolutely, absolutely. But alongside the invasive neurostimulation therapies, there has been a group of non-invasive therapies. And I don't know what devices did you see, but there are three main devices. One of them is actually NICE approved, but it's not free on the NHS, and it's called transcranial magnetic stimulation.
I think I've seen that.
It's a box.
Big one, like a box.
With handles, and when people have a migraine, they put it at the back of the head. They pull the button, and they hear like a noise, and that's the magnetic stimulation that is delivered at the back of the head, so in the occipital cortex. And this magnetic stimulation, what it does, it causes an alteration in the electrical threshold in the occipital area. So this therapy has been used mainly in migraine with aura. So we've got a randomized control trial which is positive in migraine with aura pain. But there are some new studies that have shown that it can work also if you don't have the aura and if you have chronic migraine, and you can use it as a preventive treatment. So you take it 3 to 4 times a day. Is about 1 kilo, so you can hold it in your bag and you can use it when you need it. So it's quite a handy therapy. Very well tolerated, so very few side effects, and that has been FDA and NICE approved to date. There are other 2 devices. One is the so-called vagus nerve stimulation, called also gamma core, which is a small device that is placed on one side of the neck, where the cervical branches of the vagus nerves are. And so the reason why this company has developed this treatment is because we know that the vagus system has got a lot to do in migraine pathophysiology. So some nuclei of the vagus and the branches of the vagus are connected with the trigeminal nuclei. So, and we know that migraine is associated with autonomic features, and we know that the vagus nerve is very much involved in parasympathetic activity. So because obviously doing a permanent implant in the neck can be quite cumbersome with a lot of side effects, they designed this device which is non-invasive. And so far we have a couple of good studies in the acute treatment of migraine. So you have a migraine, you apply it for 2 times, 90 seconds of stimulation, then you take it away, then you apply it again for another 90 seconds. And the treatment delivers some electricity, so the patients feel some tingling here, and the corner of the mouth can droop a little bit, and that means that the treatment has hit the nerve, the vagus nerve.
Transitory?
Of course. And then there is a good proportion, about 30% of patients that get a relief from that. Wonderful. But also gamma-core can be used as a prevention in people with frequent headaches. And there has been a study that shows that if you use it 3 times a day, there is a good proportion of patients, about 40%, that can benefit from it long term. And this is quite handy because you don't have to take tablets and you don't have to have a permanent implant. The last device is like a headband.
Yes,
so
like specs.
Exactly. So it's called cephaly device, and is a stimulation of a nerve that runs in the forehead, which is called supraorbital nerve.
Cephaly, like kefali.
Like kefali.
Ah, that's a Greek word.
Well, most of the medical words are
of
Greek.
Course.
So, and what it does, it delivers electricity to this particular target.
Excuse me, where is it applied?
So is applied like sunglasses, but without the glasses.
Okay.
And so there is a button which is pressed when the device wants to be used and to be switched on. And the treatment lasts 20 minutes. So people sit on their couch, they have the treatment on for 20 minutes, and that's it. Some people use it twice a day, but normally once a day is enough. And again, there is about 40% of people with migraine that get better. They can treat the attack and they can prevent them to occur. And I think those are very handy options for our patients, especially for those that have a lot of side effects with traditional treatments.
Are all 3 approved?
So the transcranial magnetic stimulation, as I said, is NICE approved, but it's not free on the NHS.
Is it very expensive?
So what the company does, it gives you a 3 months free trial, and if you are a responder, then you have to pay for it. Is about £150 a month.
Well, so if you think of the cost of medication and hospital visits, maybe it's not that bad.
It's not that bad if it works. And actually, the good thing is that you try it before you buy it. So if it doesn't work, if it doesn't work, you don't get it. So that's a good strategy. Cephaly is FDA approved, but it's not NICE approved, and gamma-core is not NICE approved yet.
All right. Okay.
So people get it. Well, people get it either privately or in certain situations, some centres in the UK can provide it under specific circumstances. So,
in the frame of the research, I can imagine, because you get data from these patients, and over the next few years, we have very promising things.
Absolutely.
Right. What about spinal cord stimulation? How often do we practice that? Yeah.
So Guy's St Thomas is one of the pioneer centers in spinal cord stimulation for headache. We so the problem we had with occipital nerve stimulation, we're still talking about those patients where nothing works. All the traditional treatments don't work. So in those where, so because of the mixed evidence using occipital nerve stimulation, and because of the fact that in view of the paresthesia, has not been possible to do a proper sham placebo-controlled trial, because people know that when they don't get the paresthesia, they're getting the sham. So because of that, we try to test the efficacy of another device, which is a high-frequency spinal cord stimulation of the cervical spinal cord, which doesn't produce any sensation. So patients have it, is implanted at the back of the spinal cord with a lead and battery, but they don't feel any sensation. So and it seems from initial, so we're conducting a trial right now at St Thomas's. We collaborated in a previous multi-center trial a couple of years ago, and it seems quite a promising therapy for, again, a selected population. But also the other very promising aspect is that if it turns out to be effective, then we can do a proper randomized sham control trial, which will be the first trial in the field of neuromodulation for headache.
That will be the future, and it's so wonderful to know how many steps forward you have made. What an amazing, extraordinary progress you have made, and you use all these things, because I had a quick look before I came here. I was amazed how much the human brain has achieved. Is absolutely stunning.
You're right. You're right. There has been a huge development in the migraine field, and although we can't say that we can cure migraine, we can certainly say that we can treat most of our patients with all the arsenal of treatments that we've got. And recently, just concluding on the future in migraine management. Actually, the future is even more promising than it is right now because of these new antibodies that have been studied. So
tell us about it.
So the CGRP calcitonin gene release peptide antibodies are a treatment that target the market of trigeminal activation, which is the CGRP, this peptide that is released when people have a migraine from the trigeminal system. And when you take sumatriptan or another triptan, those levels of CGRP are reduced. Now, CGRP is a potent vasodilator, and has been a target in migraine therapy for a long time. And what the researchers have done now, they've tried to use monoclonal antibodies against either the receptor of CGRP or the CGRP itself, so the levels in the bloodstream. There are now 4 molecules. There are 4 companies working on it, and the antibodies are delivered with an injection, subcutaneous or intravenous. And the beauty is that you get the injection once a month or a couple of times a month, and you're fine if you're a responder. The tolerability profile seems very, very promising. The studies are still in phase 2, so we still need to wait a few years.
Way to go.
But this is the absolutely exciting, because it's the first targeted and specific treatment for migraine, because it targets one of the molecules that is very much involved in the pathophysiology of migraine, whereas before, so far we've been using tablets that we don't know what they're targeting.
That's really impressive. It's
so this is certainly
unbelievable.
It can be revolutionary for the if you think about the next 3 to 4 years.
Do we do that here in London?
Of course, there is a trial in the UK that is underway in chronic migraine, and there has been 2 or 3 trials that has been done in the US.
All right. Again, across the Atlantic, things move really fast.
Yeah.
Wonderful. Do you want to tell us a couple of things about cluster headaches? Because, again, it's something that come across our practice very often.
Yeah. Well, so cluster headache is certainly one of the most excruciating pain conditions known to mankind. If you Google cluster headache, you can see lots of pictures of our patients.
Scary.
But they try to show to people that don't suffer with cluster headache how devastating the condition is and what do they feel during an attack. Certainly migraine is highly disabling. Cluster headache is probably one of the most painful conditions. And there has been a survey in women with cluster headache, and they said, I prefer to give birth.
Indeed.
Rather than having a cluster headache. So certainly is a devastating condition, has been underdiagnosed over time, and in turn undertreated. But it's a condition that normally primary and secondary care physicians shouldn't be missing. Is a specific headache on one side of the head, normally around the eye. The pain is sharp, excruciating, 10 out of 10. It can occur at specific times every day. Normally people have from 1 to 8 attacks a day, and it can last between 15 minutes up to 3 hours.
Is there some periodicity then? There is.
Okay. So the vast majority of people with cluster headache will have attacks at the same time every day, mainly at night. They're woken up at night. So in primary care, if you have a male patient in their 30s or 40s that report a short-lasting headache, they wake them up at night, you have to think about cluster headache.
Okay.
And the other important thing about cluster headache is that people experience, along with excruciating pain, also facial symptoms. We call them facial autonomic symptoms. So watering of the eye, redness of the eye, runny nose, blocked nose. And the main difference with migraine is that in patients with cluster headache, during an attack, they tend to be very restless, agitated. They walk around. Some of my patients actually hit their head on the wall. They don't know what to do with themselves. They can't lie still. So whereas in migraine, they tend to go to bed in a dark room. In cluster headache, this is not possible. People are very agitated, very restless. So they want to be left in their home, in their place, quiet, with the treatment that normally works, and such as sumatriptan injection and high flow 100% oxygen.
Wonderful.
So in cluster headache again, there are two variety. One is the episodic, one is the chronic cluster headache, and we use some of these neurostimulation technologies that we use in migraine, like occipital nerve stimulation, spinal cord stimulation, also in cluster headache.
Okay.
In terms of new advances treatment, I must say most of the cluster headache patient can be controlled with medications, but there is a small proportion that don't respond to medication, and for them, again, we tend to a neurostimulation treatment. So gamma core has got very positive data in cluster headache, so non-invasive. Occipital nerve stimulation works for cluster headache, and then there has been a new, very exciting device, which is probably one of the most advanced neurostimulation device because it's wireless. So there is no lead. It uses a Bluetooth technology and is implanted at the level of the sphenopalatine ganglion, which is a bundle nerve at the back of the nose, which is activated when people have cluster headache, and is the neurons, is the pathway that is responsible for the facial symptoms, so the lacrimation, the redness of the runny nose. So stimulating that ganglion seems to stop the cluster. And so there is a company that has developed this sphenopalatine ganglion stimulation, which is again a permanent stimulator. It's very small. It's placed through the gingiva at the back of the nose, screwed to the maxillary bone, and then when you have an attack, when someone with cluster headache has an attack, then they place the device on the cheek, activate the stimulation, and a good proportion of patients becomes pain-free in 15 minutes. Without taking any medication.
I'm speechless, honestly, with what you just described. I'm just speechless. What the human brain has achieved. Amazing to implant this, and it's actually activated by the pain. Is it triggered by the nerve stimulation, and then it acts itself
Stopping
without doing anything yourself within 15 minutes?
Yes. So
unbelievable.
So yeah, it's pretty revolutionary for the simple reason that you don't have leads, you don't have any battery. It used the most cutting edge technology when it comes to mobile and computer. The wireless Bluetooth technology, which is something very advanced, and I think
that's how it is charged as well.
So it doesn't need to be charged. No? So there is an antenna that receives the pulses from a little device, and then there are electrodes that deliver electricity around the area, and the neurostimulation, the stimulation of that area tends to stop the release of certain peptides that activate the trigeminal system in cluster headache. So the good thing is that you don't have to have the device on all the time, you use it on demand. So when you have a cluster, you place it on and you use it, and then you put it in your bag.
And that's it.
Yeah.
Amazing. It's more than amazing. I don't know if there are enough words to describe that. It's extremely impressive. How many things we have, and obviously it's not easy to be aware of these things. We don't know these things, and I'm so grateful that you came here today to tell us all these. I'm utterly impressed and speechless, and I'm really proud that we have this kind of medicine here, and we do all these things. And I can imagine you as a specialist, high-level specialist working in this area, and you have all these therapeutic options. It must be so handy and so wonderful to explore these opportunities to offer your patients the best. And it's a huge satisfaction, I can imagine.
It is when you can treat them. Yeah, it can absolutely.
Wonderful. I leave it to you if you want to close this discussion in any way you want. before we say goodbye tonight?
Well, yeah, no. Thank you for the. Well, I think the main message is headaches and migraines are very disabling. It's very important for our doctors to be able to recognize it. But the hope is that, because some people they don't seek any advice because they think that there is no treatment for their headaches, for migraine, for cluster headache, for trigeminal neuralgia. But in fact, as I showed, there are many available treatments. Some of them are under research, some of them are already available, and they can make a difference. So, we need to raise the awareness, even for these disabling headaches, because they are treatable conditions.
That's the very promising message to take home with, as we say. I have friends who suffer from migraines. I have some migraines, but not very often, once or twice a month. And today, I also want to dedicate, let's say, this presentation of yours, because I had a discussion with the wife of our ambassador, and she was saying, we need to know a bit more about the migraines. And, you gave me a good hint to discuss something, and we found out so many wonderful things. I'm so happy we will be able to pass this information on to people who are interested. And we would be very grateful if people can approach you. We have your details, provide to the public, and come and find you, because I'm pretty sure you will be able to help loads of people.
I hope so.
Thank you very much. Ευχαριστώ πολύ που ήρθες.
Ευχαριστώ πολύ. Πρέπει να πούμε κάτι στα ελληνικά.
Να πούμε κάτι στα ελληνικά, να κλείσουμε. Ήταν υπέροχη συζήτηση, νομίζω από τις ωραιότερες εκπομπές. Σε ευχαριστώ πολύ. Ευχαριστώ γιατί μάθαμε τόσα πολλά, έμαθα και εγώ πάρα πολλά. Εύχομαι εξίσου χρήσιμα, συναρπαστικά να ήταν και για όλους εσάς που μας παρακολουθείτε. Ευχαριστούμε πολύ που ήσασταν μαζί μας. Ελπίζω κάποια στιγμή να ξανάρθεις, αν μπορείς. Ευχαριστώ. Καλό βράδυ, ευχαριστούμε πολύ. Καλή εβδομάδα, ραντεβού την επόμενη Κυριακή. Καληνύχτα.